All right. Well, hello, everyone. I'm happy to be here with you today. So I'm coming from South Florida, an area called Boca Raton, and I'm part of Florida Atlantic University. So just a little bit more about me. I did my medical degree and residency training in Philadelphia, Pennsylvania at Drexel University College of Medicine and Hahnemann University Hospital. After that, I stayed on as faculty. I started initially with medical student education and then transitioned over to the residency role where I was an associate program director for 9 years. I've liked medical education since I was getting my medical education, and I was fortunate enough to be able to stay in it and continue to do so today. So at this point, I'm an associate program director here at FAU. I help oversee outpatient education in our clinics as well as hospitalist service on our floor teams. So I'm excited to talk to you guys today, and we're going to talk about electrolyte disorders. So probably something you guys see quite often. I have nothing to disclose, and sort of the overview of what we're going to cover today. We're going to start with sodium, since it's sort of the biggest of the topics, then move to potassium, magnesium, calcium, and phosphorus. So overall, we're going to talk about the different etiologies for electrolyte disturbances. We'll talk about the signs and symptoms of common disorders that you guys are going to take care of and probably take care of every day. And then, of course, the treatments for those common electrolyte disorders. Right, so starting with sodium. So sodium is a pretty important electrolyte. 85 to 90% of all sodium is extracellular, and that's because we have these sodium-potassium ATPase pumps that actively pump sodium out of the cells. And generally speaking, sodium loss should equal sodium gain, and if it doesn't, then you either get an edematous state or a hypovolemic state. And generally, that's because any change in the sodium concentration gets reflected as a change in water balance. And that's just because sodium and water are so intricately connected in our bodies. Just brief, going back to some renal physiology, just reminding you about the different areas in the kidney that have a role in sodium balance. So starting off in the proximal tubule, there's co-transport with organic molecules and counter-transport against hydrogen ions. And that's actually about 65 to 70% of sodium reabsorption happens in that area. Then moving into the loop of Henle and the thick ascending limb, you have a sodium-potassium chloride co-transporter. This is the site of action of your loop diuretics like furosemide and bumetanide. Moving to the distal tubule, you have a sodium chloride co-transporter. This is the one that's blocked by your thiazide medications. And then moving into the collecting duct, you have an epithelial sodium channel, and this is in the area of action for amiloride and aldosterone. So the sodium reabsorption in the collecting duct is very regulated. But just, wanted to show you this picture just to remind you where the drugs are working and where the sodium is predominantly getting moved around. So we'll start off with hyponatremia. It's probably one of the more difficult topics or nebulous topics just because it is pretty involved when you have to go into the evaluation. So hyponatremia is defined as a sodium level of less than 135 milliequivalents per liter or millimoles per liter. So generally speaking, once you know that the person has hyponatremia, your next step is really to figure out what's their serum osmolality and what's their tonicity. So this chart is taken from a review book called the MixApp series, and it's what many of our students in the United States and trainees in the United States use to study for their medicine boards. So looking at the flow chart, if you just follow it along, the serum osmolality, you come down and you check that, and if it's hypertonic, that means it's greater than 295 milliosmoles per kilogram of water. If it's hypotonic, it's less than 275, and if it's isotonic, meaning normal, it would be between 275 and 295. So once you know that it's hypotonic, then you have to actually look at the volume status of the patient. Are they hypervolemic, fluid overloaded? Are they hypovolemic, not enough? or are they isovolemic? And then from there, you can measure urine osmolality to get to the next steps. So we're gonna dive deeper into this, but this is just sort of the big overall picture of the approach to hyponatremia. So starting off with hypertonic hyponatremia, the number one reason is usually glucose. So there's usually too much sugar in the serum, and for every 100 points above the normal in glucose, you get a 1.4 millimole per liter fall in sodium. Sometimes mannitol can be the agent that's responsible, but again, it's a glucose type agent. And the reason why is it's a very effective osmol. So water follows it. So by pulling that water out of cells, following the glucose, you basically dilute out the sodium in the serum. For isotonic hyponatremia, you're not going to see this a ton. There's sort of a couple main circumstances. One is patients who have had either transurethral resection of the prostate, TURP, or transurethral resection of the bladder, TURB, and that's because they irrigate the bladder with a mannitol or sorbitol solution typically. And again, because of that high osm content, it's pulling a lot of water, and therefore it's causing the patient to get hyponatremic. On the other hand, what you probably would see more often would be this situation called pseudo-hyponatremia. And this is where you have an increase in what's considered the solid components of plasma. This is your proteins and your lipids. Normally, our plasma only has about 7% of the composition made up of proteins and lipids, but in circumstances where you have very high protein states or high triglyceride states, you might see a pseudo-hyponatremic state simply because the plasma is more solid than it should be. So multiple myeloma is probably something that you guys would see this in, as well as patients who have hypertriglyceridemia. So hypotonic hyponatremia is really sort of where most of your patients are going to be, and the ones that are going to require sort of the most intensive workup. So in very broad terms, hypotonic hyponatremia is either a primary gain of water or a primary loss of sodium. So in order to really know what type of hypotonic hyponatremia the patient has, you have to determine their volume status. So this chart sort of reviews the main causes of the different different volume states associated with hypotonic hyponatremia. So looking at the left-hand side of the chart, hypovolemia, these are your patients that are losing water from insensible losses. Are they sweating? Do they have burns? People who have GI losses, whether that's vomiting or diarrhea, or some of the high output fistulas and ostomies. And then, of course, renal losses, diuretics, so medications we're giving them to take off fluid, osmotic agents, hypoaldosteronism, the post-obstructive diuresis state, and then non-oliguric ATN. On the right side of the chart, the hypervolemic patients, these are pretty straightforward. These are your heart failure patients, your cirrhotics, your nephrotics, where they just don't have, in this circumstance of cirrhosis and nephrotic syndrome, they just don't have the oncotic pressures to keep fluids from extravasating, so they end up becoming just overloaded with volume. Euvolemia, on the other hand, these patients are able to maintain a normal volume status despite the fact that, for instance, in the situation of primary polydipsia or beer-potomania, they're taking in large quantities of liquid. And how you sometimes can tell the difference between primary polydipsia and beer-potomania is really looking at their urine output. So a patient with primary polydipsia is probably going to put out around 12 liters of urine a day, whereas somebody who has beer-potomania might only put out about 5 liters of urine, which is still a lot, but the difference is that they basically aren't taking in any other solutes. They're generally just drinking beer, whereas somebody with primary polydipsia is taking in other solutes as well. They're still eating, so that's why they can generate a higher volume of urine output. You also see euvolemic states with situations that cause release of ADH or antidiuretic hormone. So this is actually in physiologic circumstances like nausea or pain, and also certainly related to drugs that cause release of ADH. You can also have SIADH, which we will talk about on the next slide, hypothyroidism, CKD, and deficiencies in the glucocorticoids. SIADH is something that, you know, at least my residents and myself personally, we're always really excited to diagnose, because it usually is sort of a cool diagnosis, and depending on the etiology, you can turn it around pretty quickly. So there are a bunch of medications that will cause SIADH, thiazides, and the selective serotonin reuptake inhibitors, or SSRIs, used for depression and anxiety. Those are probably the biggest ones that we see here in the United States. Also Haldol, carbamazepine, valproic acid, you know, things that are used in epilepsy. TCAs, or tricyclic antidepressants, probably was more of a cause for us in the United States years ago. We don't use a ton of TCAs anymore, but there are still patients that are using them for various conditions such as fibromyalgia and pain. Phenothiazines, clofibrates, bromocriptine can cause an SIADH picture. Cyclophosphamide, and then also drugs of abuse such as ecstasy. Certainly the SIADH that we hate to see is the one that's caused by malignancy, most commonly a small cell carcinoma of the lung or a squamous cell of the head and neck. And then you can have SIADH from just straight up CNS disease, pulmonary diseases, endocrine disorders such as glucocorticoid deficiency or myxedema, and then idiopathic, because we sometimes don't know what the SIADH is from. And then endurance runners can actually develop an SIADH, I guess, sort of in response to their intense training. So when you're going to diagnose somebody with hypovolemic hypotonic hyponatremia, or excuse me, hypotonic hyponatremia, sorry, there's a lot of hypos, you have to take a good history. It's really important that you ask all the questions about what they've been doing, what medications they're taking, what exposures they might have, what's their past medical history, what surgeries have they had, because all those things could come back and play a role in what's going on today. In addition, a good physical exam, making sure that you're paying attention to things like their neurologic status, their muscle tone, what's happening with their volume, are they volume overloaded, are they dry or dehydrated? And then, you know, thinking about how these patients present to us. So when it comes to hyponatremia, timeline is really, really important. So if hyponatremia develops over a short period of time, like within a 48-hour period, that would be an acute hyponatremia. And these patients generally present in a pretty striking way. It starts off with things like nausea and malaise, lethargy, headache, just a little bit nonspecific, but then it'll progress to more confusion, obtundation, seizures, and then of course they can even progress to stupor and coma. So the pictures that I've shown here, these CAT scan pictures, are trying to show you the amount of brain edema that you can see as a result of hyponatremia. And that's because you get these shifts of water, and the brain isn't good at managing the acute shifts. So you get this brain edema that develops, and that is what leads to these seizures and neurologic symptoms. So it is really important to identify it quickly if you think it might be happening. And then when you go to the stance of treating it, if it's a mild hypovolemic hyponatremia, you generally just give them back fluids. And ideally, you know, like most things, if you can give it orally, we want you to give it orally. If it's more severe and you need to use IV fluids, we generally use an isotonic normal saline solution, which provides 154 millimoles of sodium per liter. If the patient happens to have diarrhea as the cause, you oftentimes want to add some bicarb, since they're losing a lot of bicarbonate, and that's going to actually worsen their hyponatremia if you don't also correct that. If they're bleeding and you can give them blood back, that's what you would most want to do. And then in your patients who have hypervolemic hyponatremia, these are your heart failure cirrhotics, your nephrotic patients. If you can treat the underlying issue, that's great, but since we can't always fix a cirrhotic or give back the proteins that a nephrotic patient is losing, water restriction generally is the direction that you have to take with these patients. For your isovolemic hypotonic hyponatremic patients, if they have acute changes, meaning this sodium dropped within a 48-hour period, they're having those neurologic changes due to the brain edema, then you do have to treat them more aggressively. So you can, and I say can only because this is still a very risky thing to do, you can give 100 milliliter bolus, so a very small amount of a 3% normal saline solution. So basically 3 times as strong as the normal saline that we would use. And you want to make sure that you're watching that sodium very closely. Essentially, you're checking that sodium probably every 2 hours, at very minimum every 4 hours. There are some other agents that block receptors, so the V2, V1A antagonist that's called conivaptan. That can actually block the effects of ADH. It can help increase urine output. And this is an IV medication that can be given as a 20 milligram IV load over a 30-minute period, followed by another 20 milligrams over the next 24 hours. There's an oral agent called tolvaptan that you can use if the patient is able to take oral medications. It's 15 milligrams by mouth, and you can adjust the dose every 24 hours so that they can be up to 60 milligrams a day if needed. Again, when you are trying to correct this acute hyponatremic patient, you are checking sodiums every 2 to 4 hours because you want to make sure that you're getting it in the right direction and not going the wrong way. Probably the ones you see more commonly, though, are your chronic hyponatremic patients. So in these patients, the sodium has gradually fallen over time, which means you want to be gradual in your replacement. You don't want to be aggressive. These are the patients where you really have the risk of that osmotic demyelination syndrome developing if you correct them too quickly. So generally speaking, rule of thumb, we say that you want to see an 8 to 10 milliequivalent per liter rise in the sodium over that first 24 hours. The first thing we often do is restrict their water intake. So you look at their daily urine output and try to aim for 500 milliliters less than that. Water restriction can sometimes be difficult. Patients oftentimes are thirsty or feel the need to drink things, and you have to keep in mind that they might be getting water from non-liquid sources. So they might be eating fruit or eating vegetables that have a lot of water content. So you have to be mindful of that as you're trying to restrict their water intake. We oftentimes will use tolvaptan in these patients. Again, it's a very easy drug to dose. It's between 15 and 60 milligrams once a day. It's given orally and usually very well tolerated. Demeclocycline is a drug that will inhibit the release of ADH, essentially leading to like a nephrogenic DI picture that's reversible, meaning as soon as you stop the drug, it doesn't happen anymore. And this drug you dose at 150 to 300 milligrams 3 or 4 times a day for up to 2 weeks. And then there are some patients who you'll use steroids in. Fludrocortisone generally leads to a sodium retention, and the dose is 0.05 to 0.2 milligrams BID. You just need to be careful with using this drug because given the fact that it leads to sodium retention, it actually will waste potassium and potentially lead to hypertension. So you do need to keep this person under close monitoring if this is the route that you're going to treat the hyponatremia. So hyponatremia is on the one spectrum, and on the other end of that is hypernatremia. So these are circumstances where the sodium level is greater than 145 millimoles per liter. And generally speaking, if the sodium level is high, the osmolality is also high, which leads to a volume contraction in the intracellular spaces. So typically, if your sodium level is up and your osmolality is up, the appropriate response of your body is to secrete a maximally concentrated urine, meaning you're trying to retain water, and you're thirsty, so you want to drink things. And this is all due to the release of AVP or ADH. So what are the most common reasons? Typically, you're losing water from some source. You can lose it from the kidneys, which is generally the most common cause. We do it to people by giving them diuretics. Osmotic diuresis, number one cause of that is similar to previous. It's glucose. So hyperglycemia can actually lead to hypernatremia in some cases. And then diabetes insipidus is another way to lose water from a renal source. And then non-renal sources, similar to what you'll see in other cases, these are those insensible losses through the skin, through the respiratory tract, and then any GI losses through things like nausea, vomiting and diarrhea. So similar to hyponatremia, when you're evaluating a patient with hyper, you want to make sure you take a good history. Find out what symptoms they have. Find out what medications they take. And from a neurologic and mental status exam, those are your big focuses when you're doing your exam. And you want to document exactly what their mental status is like, exactly how cooperative they are, what are their deep tendon reflexes, what is their motor strength, how coordinated are they. And you want to look at their urine. You want to see the volume of urine they're putting out as well as the concentration of that urine. So this chart comes from Harrison's Principles of Internal Medicine. And it's sort of, again, a little flow sheet talking about what you're looking at when you see these patients. So if the extracellular volume is increased, that's probably because we did that to them. We gave them sodium or we gave them sodium bicarb. If it's not increased, you look and see what their urine looks like. Are they putting out a tiny bit of really concentrated urine? If they are, it's probably, that's appropriate because they basically are losing water from some other source, whether that's from their kidneys, their GI tract, or insensible losses from the skin or the respiratory tract. If they're not, then you have to say, well, what's going on in their urine? They must have some other osmol that's causing them to excrete. So you see whether there's glucose hyperglycemia going on, or if they're on some diuretic. And then you can actually give them a challenge with desmopressin if they're not excreting a high amount of osmoles to see whether it could be a central DI or a nephrogenic DI. So we'll talk a little bit more about those things. So diabetes insipidus can either be caused by the brain not secreting enough ADH or AVP. They're sort of two names for the same hormone, arginine vasopressin or antidiuretic hormone. Same thing, used interchangeably, so I apologize if that gets confusing in the talk. For nephrogenic DI, the brain is producing it, but the kidneys aren't responding to it. They're resistant to it for some reason. So central diabetes insipidus, these are generally seen in cases of some destruction to the neurohypophysis. So the patient that has postpartum hemorrhage, or the patient who has some other pituitary disorder that leads to DI. Idiopathic causes, and then there are a couple odd hereditary ones that are inherited autosomal dominant, and it's a precursor gene to AVP that's mutated, so they just can't produce AVP. Hereditary stuff, generally in the realm of adult medicine, it's not that we would see it so much. This would present in the pediatric realm. On the other hand, nephrogenic DI, you can have congenital causes again, so either an X-linked recessive mutation in the V2 receptor gene or mutations in the autosomal aquaporin 2 gene. So the aquaporin 2 is that water channel that gets inserted into the collecting ducts to help with water and sodium reabsorption. Sporadic causes of nephrogenic DI, various drugs, hypercalcemia, hypokalemia, anything that causes the medulla not to be able to do its job, so papillary necrosis or osmotic diuresis. Pregnant women, so the placenta actually secretes a substance called vasopressinase, so therefore they can develop a nephrogenic picture. And then iatrogenic, so if you accidentally give a patient hypertonic saline or sodium bicarb, you can actually cause a nephrogenic DI picture. So why is hypernatremia a big deal? What do you see? So generally, again, like we talked about, if your sodium level goes up, your brain's natural instinct is to make you thirsty and make you want to pee. You may see volume depletion symptoms depending on what the cause was. And from a neurologic standpoint, the brain does not like changes in sodium and water. So it's similar to the hyponatremic side effects where you get changes in mental status, weakness, general irritability of the neuromuscular axis. You can see focal deficits, coma, and seizures. So again, why do these things happen? So you have a high tonicity, the water shifts out of the cells as a response to that, the intracellular volume contracts. So on this hand, when the brain volume contracts, you actually become at risk for things like subarachnoid hemorrhage and intracranial hemorrhage. So you really want to make sure that you're paying attention to these patients that have hypernatremia, because you don't want that brain tissue to start contracting and put them at risk for things like a bleed. Again, just like in hyponatremia, your symptoms really depend on how fast that sodium has gone up. So how do you treat these patients? Well, the first thing you need to do is treat the underlying issue. So stop the loss of water. There's a formula for water deficit correction where you can take the total body water estimate, calculate what the free water deficit is based on what their current sodium value is versus the normal of 140. And then over a 48 to 72 hour period, you administer that deficit of free water back, and trying not to drop the sodium more than about 10 millimoles over each day. If you can use the GI tract and use water by mouth or by a feeding tube, that's preferred. If you need to use IV, then you have to use a D5W or a half normal saline solution in order to really correct that water deficit. If the patient has diabetes insipidus, and if it's a central cause, meaning they don't have AVP production, then you actually have to replace that with an intranasal DD-AVP spray. And generally, patients who have central DI and get DD-AVP, they are fine, and they generally live normal lives and don't have any problems. If it's a partial DI, meaning they produce some but just not enough, you can actually do a low salt diet with a thiazide. That will usually correct them enough and keep them in a normal range. And then you can sometimes give medications that stimulate AVP secretion or that improve the action of AVP on the kidneys. So things like fluropropamide, clofibrate, carbamazepine, and NSAIDs. You might notice that carbamazepine was also on the list of drugs that can cause SIADH. So, probably not your drug of choice if you're going to be doing that, but you do want to just sort of keep an eye on it if that's your only option to treat the hypernatremia. So for patients who have nephrogenic DI, again, you want to look for the underlying disorder and or remove the causative agent. So again, you can use a low salt diet with thiazide. That's going to cause a volume depletion, which leads to increased proximal resorption of salt and water, and therefore decreased delivery to the site of AVP action on the collecting ducts. I'm not sure how much you guys see lithium use, but lithium was a long-standing agent used in the United States for the treatment of things like bipolar disorder. And unfortunately, lithium is taken up by the kidneys in the collecting duct cells. And it's that amiloride sensitive sodium channel, the epithelial sodium channel in the collecting duct where the lithium is taken up. And lithium can lead to not only a DI picture, but it actually can lead to chronic kidney disease and actually put people on dialysis. So if you have a patient that needs lithium, sometimes you can mitigate the effects of the lithium on the kidney by actually having them take amiloride, meaning it's blocking that channel in the epithelial sodium channel that would also take up the lithium. Okay, so that's completes the first part, and I will honestly tell you the first part was the hardest because sodium is sort of, I think, the toughest of the electrolytes to get through. So the next section should go a bit smoother. So we're going to move on to potassium. So hypokalemia is defined as a serum potassium of less than 3.5. Symptoms that patients might describe: weakness, fatigue, cramps in their muscles, constipation, and then in more severe cases, things like arrhythmias and respiratory failure. So EKG-wise, we get pretty excited if we see EKG changes related to hypokalemia or EKG changes in general. So what you look for on your EKG are these downsloping T waves followed by an upsloping U wave. And that's the classic EKG finding for hypokalemia. And here it is sort of looking at a larger EKG, the 12 lead, but you can see over here in your lateral leads, sort of V3, V4, V5, these very clear deep T waves followed by these upsloping U waves. And you can even see them a little bit over here in the 1 and 2 leads. So that's what you're looking for if you happen to have an EKG in a patient who has hypokalemia. So again, sort of a large chart for you to go back and look at later on. It's looking at the causes of hypokalemia and sort of how do you think about them? How do you break them down? So this is again taken from that review book I told you about, MixApp 18. So it can be caused by either disorders of the internal balance of potassium, disorders of external balance, or something called pseudo hypokalemia. So internal balance, we're going to break this down sort of slide by slide, but once you get to the big picture, this is what it looks like. So we're going to go piece by piece, just because I think it's hard to look at it on this large slide. So if you go on to the side of internal balance etiologies, so what are the things that lead to hypokalemia? Well, one is insulin, and insulin will drive potassium into cells. Beta-2 agonists, so albuterol, that will also drive potassium into cells. Contrast agents such as barium or cesium, that blocks the exit of potassium from cells. If you have patients who are very deficient in B12 or folate and you start repleting them, you get consumption of potassium in the process of cell production, so their potassium can drop. And then patients who have periodic paralysis can also have a hypokalemic state. Just keep in mind that insulin and beta-2 agonists have a very transient effect on potassium levels, so it's temporary. It's only going to last a couple hours. Balance, external balance issues, things like poor intake. If you have a patient who has a very compromised diet, they may get hypokalemic, but it takes pretty severe dietary compromise to get to that point. More likely, they're getting rid of too much potassium, so either through their kidneys or through their GI tract. You can do what's called a spot potassium creatinine ratio, and if it's greater than 13, that implies that it's a renal loss. And then from there, you decide, do they have metabolic alkalosis, yes or no? The most common GI reason to get hypokalemic is diarrhea. So, we almost always tell patients who are having diarrhea, even if they're at home. I do a lot of outpatient medicine. So if I have a patient that calls me up and says I have a lot of diarrhea, I usually tell them to eat some extra potassium because I know they're losing it in their stool. So as I mentioned, you have to look and see what their metabolic state is. Do they have metabolic alkalosis or not? So if the potassium is low, but they are not having an alkalotic state, then it's usually due to medications. And the common ones are things like diuretics, aminoglycosides, cisplatinum, a chemotherapy agent, and then amphotericin, which we use in fungal infections. If they have coexisting hypomagnesemia, that can also lead to hypokalemia. Certain anions, such as ketoacids or bicarbonate, can actually lead to hypokalemia, and then some of the renal tubular acidosis states. If you are giving patients diuretics, aminoglycosides, cisplatinum, amphotericin, you generally have to monitor their electrolytes pretty closely. I can tell you from experience, amphotericin patients, they're in the hospital, they're usually very, very sick, and these patients literally need a ton of electrolyte repletion. Potassium is just one of them. So you're going to do daily blood draws on them. Your patients as an outpatient who are taking things like diuretics, you're going to monitor them probably every couple months with blood work, but not every day. Aminoglycosides at minimum, if you're on long-term aminoglycoside treatment, you'd at minimum do it once a week. But, again, these patients oftentimes are sick in the hospital, so you're monitoring it on a daily basis. Cisplatinum for chemotherapy, those patients, because they're getting chemo on a regular basis, are generally getting labs every couple weeks or every month at the latest. So if, on the other hand, they do have a metabolic alkalosis, this is typically due to vomiting because they're losing all that hydrogen ions coming from their stomach. Or, remember, they don't have to vomit. We could be doing it for them, meaning they have an NG tube that's on suction. There are some genetic conditions that will cause defects in the renal tubular system. So these are Little syndrome, where you get an increase in sodium resorption in the proximal tubule that leads to hypertension, a metabolic alkalosis, and hypokalemia. Another sort of relative is Barter's and Gittleman syndrome, and those are where there's mutations in the transporters that actually mimic the diuretic effect. In some cases, hyperaldosteronism will lead to this, and these patients generally will have that triad of hypertension, metabolic alkalosis, and hypokalemia. And then if they have an apparent aldosterone excess, meaning it's not that they truly are hyperaldo, but they have more aldo than they should have. So what do you do for these patients? So these patients generally need aggressive repletion. And that's because the effects on the heart and the effects on the neuromuscular system are so concerning. So generally, the rule of thumb is that a 10 milliequivalent dose of potassium will raise the serum level by about 1 milliequivalent or 1 millimole. So for a peripheral IV, you can generally go 10 to 20 milliequivalents an hour, and usually it's potassium chloride that we use. If you have a central IV, meaning it's going into the IJ or to the subclavian or the femoral, you generally can go as fast as 40 milliequivalents per hour. These patients would be on a telemetry monitor if you were doing that. If you are using oral solutions, potassium chloride can be pills or solution. Potassium phosphorus, KPhos, or potassium bicarbonate or potassium citrate, you might use those if there's an acidosis setting. And then you can use potassium-sparing diuretics like amiloride or spironolactone to help control some renal losses. As I mentioned, hypomagnesemia can worsen hypokalemia, so you want to make sure that if the potassium is low, you look at that magnesium level and replete that if needed as well. One little thing to keep in mind about IV repletion with potassium chloride, it burns in an IV. So if you are using it in a peripheral IV, you want to try to make sure your patient has a good larger bore IV in a bigger vein. Using the little IVs in the hand or in the forearm somewhere, that's generally going to burn, and that's oftentimes the nurses have to slow down the rate of infusion or have to piggyback it onto other IV fluids just to try to dilute out that burning effect. Patients will also tell you, in case you have never had it yourself, potassium chloride tablets are quite large. They're generally like a pretty large pill to swallow. Potassium chloride liquid apparently is very foul tasting. So your patients may not be thrilled about taking those things. And especially patients who have any trouble swallowing potassium chloride pills, you want to, be mindful that they're going to be able to swallow a large pill if they have any difficulties. All right, so we're going to shift gears now and talk about the other side of potassium, so hyperkalemia. So I don't know if you guys know who the Minions are. The Minions are a cartoon series. Well, they're cartoon characters in a host of a couple different movies. They started in a series called Despicable Me, and they're these little yellow funny creatures that love bananas. So even though bananas aren't necessarily the #1 cause of hyperkalemia, I think everyone sort of puts bananas and potassium together. So hyperkalemia generally means that the level of potassium is greater than 6.5 milliequivalents per liter, or if they have EKG changes, anything above 6 counts as hyperkalemia. So symptom-wise, how do these people look? Weakness, they might have a slow heart rate, bradycardia. They might develop arrhythmias, including sinus arrest or idioventricular rhythms, and then in bad cases, VTAC, VFib, or asystole. You worry about things like ascending paralysis causing a respiratory failure, and then hyperkalemia can actually worsen a metabolic acidosis, meaning because the potassium level is high, the kidneys actually have trouble excreting acid, so it just sort of perpetuates things. This is a really nice picture of sort of what happens to your EKG as your potassium level goes up. So if you start sort of down here, remembering that extracellular potassium affects repolarization. So repolarization on your EKG is really those T waves. So that's what you see changing first. So you see your T waves start to get more peaked or more tented. Eventually it starts affecting intracardiac conduction. This is where you start losing your P waves, all right? And then if it gets even higher, you can imagine a string pulling at your T waves and pulling at your P waves, sort of straightening them out, widening your QRS. And then as that QRS gets wider and wider, what's the next thing to happen? You get this scary sine wave pattern and eventually VFib. So if these are why, if you have a patient who has hyperkalemia and they're starting to hit the range of 6, you really want to be paying attention to their EKG. If you can do it sooner, great, but at a minimum, once they hit that 6 number, you need to know what their EKG looks like, because if they are showing some of these signs, you need to get that potassium under control. This chart, again, for you to go back and look at later, this is, again, out of Harrison's textbook, looking at sort of the flow sheet of how do you approach hyperkalemia. When do you worry, and what sort of tests do you do in what order? So we're going to go through this in a little bit more detail, but just a couple highlights. Pseudo-hyperkalemia, this is the state where the potassium level is high, but falsely so. This is a case where a patient's a difficult stick, and so the tourniquet's on their arm for a really long time, and that tight tourniquet causes breakdown of the cells, and so when they get that sample of blood, there's already cell lysis, which leads to a release of preformed potassium. So not that the potassium level is high, it's high artificially because of that tight tourniquet. If the patient's got their fist really clenched during the blood draw, that will also potentially cause this. Any cell lysis conditions, and also any leukocytosis or thrombocytosis can lead to a pseudo-hyperkalemia. So if you have a high K, make sure you're double checking your other lab values to see if those might suggest what's going on. Or if you happen to know that that was a difficult stick and the nurse had trouble drawing the blood, or you personally had a lot of trouble drawing the blood, then you may just want to recheck it before you go acting on it. Okay, so we're going to move to the next slide and talk a little bit sort of in this section about transcellular shift. So what are situations in which the potassium is just moving from intracellular to extracellular? So these are things like acidosis, and that's because we have a hydrogen potassium exchanger. So it's trying to correct the acidosis, and in doing so is shifting the potassium. Hyperosmolar states, so radio contrast, dextrose, mannitol, these produce what's called a solvent drag, meaning they are very osmotic agents. They're pulling water out of the cells, and potassium generally is following. Beta blockers that are not cardioselective, they put this on all of the charts for hyperkalemia, but I can tell you, in all the patients I've taken care of, I can't say that I've ever found one that was specifically just because of being on beta blocker therapy. On the other hand, digoxin and its related glycosides, that drug actually inhibits the sodium potassium ATPase and then impairs the potassium uptake. So that's why you do have to monitor things like potassium very closely when you're giving a patient digoxin as a treatment. There is a variety of periodic paralysis that's the hyperkalemic state. You have some amino acids, such as lysine and arginine, that have a cation potassium exchanger. So you get an exchange of a similar positively charged cation. Succinylcholine causes a efflux of potassium through some acetylcholine receptors. And that's why you also see a similar effect in things like muscle injuries, thermal trauma, disuse atrophy. Again, because you get this acetylcholine receptor causing an efflux of potassium. It's also why if you're going to use succinylcholine for induction for intubation, you want to know what their potassium level is to start with, because if it's on the top end of normal, you probably don't want to give them succinylcholine because you might actually make their potassium too high. And then tumor lysis, again, because you have a turnover of cells and you get a shifting of potassium. Overindulgence or sort of the dietary sources. So bananas is just one of them. Citrus fruits like oranges are actually a really common way that we see here in the United States, especially orange juice. But there's also other stuff that has potassium in it. So pumpkins, dried fruits, various beans, including kidney beans, garbanzo beans, black beans, some seeds and nuts like peanuts, almonds, pistachios. Avocados have a fair amount of potassium, as does spinach. So, I think people oftentimes think of just bananas, but it's really more than bananas. But usually we like to blame the kidneys. So, I would say in a lot of instances it is related to kidney dysfunction. Either the kidneys are just not kicking out enough potassium, usually if they have oliguric renal failure with a low GFR less than 20. If we're giving them potassium-sparing diuretics, we're causing the K to go up. There are some medications that indirectly affect potassium excretion, so trimethoprim and pentamidine. They block that epithelial sodium channel and therefore can lead to some hyperkalemia. And then NSAIDs through the decrease in renin can also lead to it. There's also something called pseudo-hypoaldosteronism, which you may or may not see, but basically looks like a hyperaldostate, or excuse me, looks like a hypoaldostate, but isn't. So true hypoaldosterone states, if the renin level is high, it's usually something like primary adrenal insufficiency, ACE-ARB therapy, or ketoconazole treatment. On the other hand, if the renin level is low, that's seen in things like diabetes, glomerulonephritis, tubulointerstitial disease, NSAIDs, beta blockers. For adrenal insufficiency, the most common causes are things like HIV, tuberculosis, and then of course autoimmune conditions. For tubulointerstitial disease, you basically have a hyperkalemia that's out of proportion to the GFR decrease. Things that might lead to this: amyloid, sickle cell, interstitial nephritis, obstructive uropathy. So, you know, you generally have to get sort of a bigger picture if you suspect that that's the etiology. So what do you do for hyperkalemia? Well, remember when I showed you those EKG changes that can happen? Treatment is really urgent. You need to stabilize the cardiac membrane. You need to keep this patient from going into one of those fatal arrhythmias such as VFib. So calcium gluconate, we generally call it an amp of calcium gluconate, which is 10 mLs of a 10% calcium gluconate given IV over 2 to 3 minutes. You can also use a calcium chloride. It generally will see the effects within 1 to 2 minutes, and it'll last 30 to 60 minutes. So this is why get that EKG as soon as you see the potassium level being elevated. If there are changes, give them calcium gluconate, and then you need to work on moving that potassium. So there are a couple agents that you can give that will push the potassium intracellularly. Remember we talked about in the hypokalemia side, insulin and beta agonists? Well, you can use that to your advantage. So you can actually push 10 units of regular insulin with a 25-gram glucose push as well, because you don't want to drop their sugar. You'll see the effects of the potassium go down within about a 10-minute period. It peaks at about an hour and lasts up to 6 hours. Beta agonists like albuterol, so you put them on a nebulizer. This works a lot slower. You see it take effect in about a half hour, peaks at 90 minutes, and will last, again, up to 6 hours. But these are just temporizing measures. So again, you're doing it on the urgent basis because you need to get the potassium down, but you still need to get the potassium out. So that's when you have to move to things like Hypercalcemia or a sodium polystyrene sulfonate. It's a 15 to 30 gram dose, and it's actually in a 33% sorbitol solution. So it's very, very sugary. And it basically works as an osmotic agent and makes the patient have a bowel movement or several bowel movements to get rid of potassium. It could take up to 24 hours, so that's why this is not your first step. This is really more of the longer acting thing. You might need multiple doses of this. There is just that side note of the potential for intestinal necrosis. It's a bit theoretical as a concern, but do be mindful of that if you are using Hypercalcemia, especially in multiple doses. There is a polymer called patiromer that will exchange potassium for calcium, but you have to keep an eye on the magnesium level. You can use loop diuretics to actually help push out potassium, and then in severe cases, such as those patients who are developing those bad EKG changes, then you probably need to throw a dialysis catheter in them and get them dialyzed as soon as possible. Okay, so moving on to the next electrolyte that we're going to discuss, it's magnesium. So remember I said in the last group of potassium, magnesium oftentimes they're sort of partners in crime. So when one's off, the other's off, and to fix one, you have to fix the other. So why is magnesium important? Well, it's crucial, again, along with calcium and along with the other electrolytes for normal neuromuscular activity. It actually forms complexes with ATP. It works as a cofactor with different enzymes and transporters and nucleic acids. And it's from an absorption standpoint, we take it up in the jejunum and the ileum. stimulated by the 1,25-dihydroxyvitamin D. So hypomagnesemia is a level less than 1.7 milligrams per deciliter. And the cause is sort of similar to all of the others. You can have a GI cause where you're just not taking it in or absorbing it well. You can have loss because you're throwing it up or having diarrhea. You can have ostomies or surgical drains or NG suction that's causing it to go out. And then PPI, or proton pump inhibitor usage, in the long term can lead to low magnesium levels. So we use a lot of proton pump inhibitors in medicine because of the incidence of things like peptic ulcer disease and just, you know, symptomatic GERD or reflux. But really, patients who are on them long term do need to have magnesium levels checked in, periodically because it will leach out magnesium. Hold on one second. I can't talk right now.
Okay.
Sorry about that. The other thing that can happen is the kidney tubules have impaired reabsorption. You can have wasting of magnesium from some genetic syndrome. You can get tubular issues from remember we talked about the Bartles and the Gittlemans, that can also cause a wasting of magnesium. From a tubulointerstitial disease standpoint, the diabetes, SIADH, those things can lead to some tubular interstitial problems. You can have post-obstructive issues, various drugs, cisplatinum, like we mentioned with potassium, aminoglycosides, pentamidine, amphotericin, cyclosporin, diuretics. These are all things that will also lead to hypomagnesemia. So again, just like in the potassium section, you need to be monitoring electrolytes in patients that are on those medications because they will end up needing repletion at least at some point during therapy. There can be rapid shifts from the extracellular fluid into cells, bones, or third spaces, often seen in refeeding syndromes as the patient is having respiratory respiratory acidosis that's being corrected. Pregnancy can cause this as well. And then alcoholic patients, this is a common thing that we see in the United States. It's sort of the dietary way to get deficient in magnesium. And these patients oftentimes will have quite low magnesium levels and have to be repleted. So what are the symptoms of hypomagnesemia? So you usually have to have a pretty low level in order to get symptoms. So even though it's defined as a serum level less than 1.7, you usually are down around 1.2 or less when you get the symptoms. And the symptoms, again, sort of going back to that idea that it's neuromuscular stuff: tetany, tremor, seizures, weakness, ataxic gait, nystagmus or vertigo. And then some of the psych side of things, or the mental status: apathy, depression, general irritability, being delirious, or even being psychotic. EKG wise, you can get, again, prolongation of the PR and QT intervals, flattening of your T waves, straightening of the ST segments, and you do need to be extra mindful of your patients who take digoxin to make sure that their magnesium levels are okay, because hypomagnesemia will actually enhance the sensitivity to digoxin toxicity. So how do you treat it? Well, if it's mild, if they're in that like 1.2 to 1.7 range, they're not showing symptoms, you can give them oral magnesium salts. The downside to that is diarrhea generally develops, or at least develops a pretty robust bowel movement right afterwards, usually with some cramping. If it's more severe and symptomatic, so if they're down in that less than 1.2 range, usually need to do IV. And you can give anywhere from 1 to 4 grams IV over a 2 to 4 hour period of either magnesium chloride, or we use typically magnesium sulfate. If you are looking at magnesium as a problem, make sure you're not looking or not overlooking the others: the calcium levels, the phosphorus levels, the potassium, and your vitamin D, because generally a derangement in magnesium is going to also have a derangement in at least one of those. So switching to the hypermagnesemia state, how do you get a high magnesium level, which is defined as greater than 2.4? Well, you can have too much intake. That's a tough one, although there can be some magnesium-based cathartics that will do this. You can have mobilization from soft tissues, so burns, trauma, shock, cardiac arrest. The kidneys might not be dumping it out like they're supposed to, and then other conditions like adrenal insufficiency and hypothyroidism will lead to this. So what are your symptoms? Well, the good news is you generally never get to these symptoms until the level is very high, at least 4 or 5. But vasodilatation is probably one of the ones that's easiest and most early seen. And what you might see is just that their blood pressure is low and you don't seem to get it to come up with fluids or vasopressors. So that's something to keep in mind. As the magnesium level goes up, things like nausea, lethargy, weakness, GI ileus, respiratory failure, they might develop a coma, and then just looking sort of more bigger picture stuff, flushing, pupillary dilatation, bradycardia, and heart block. So again, paying attention to a lot of cardiac and neuromuscular stuff. How do you treat them? Well, if they're ingesting something, you give them something to make them get rid of it, but you make sure it's magnesium free. If their kidneys aren't functioning well, you may have to do dialysis. You generally are going to hydrate these people very aggressively and give calcium to stabilize the cardiac membrane and also help the symptoms. All right, so we talk about calcium. Let's do that next. So why is calcium important? So calcium has a role with both our bones as well as neuromuscular function. It's very tightly bound to albumin. Therefore, if the body has low albumin levels, you need to correct the calcium level, or you need to check an ionized calcium. So I gave you the formula to correct calcium using albumin, and that's an important one for you guys to remember. This chart just sort of goes over how calcium is also interrelated to multiple things: the bones, the intestines, the kidneys, the parathyroid glands. So basically you get this feedback mechanism that as the calcium level in the blood goes down, the first thing, the parathyroid increases PTH. That acts on the bones to increase resorption. It also acts on the kidneys to stimulate the production of 1,25-dihydroxyvitamin D, which makes the intestines resorb more calcium to try to help elevate that calcium level. So hypercalcemia is typically the most common etiologies are primary hyperparathyroidism and malignancy. In fact, 90% of cases are going to come from those two diagnoses. Other things that can do it: medications such as thiazides or lithium, vitamin D activity increase in conditions like tuberculosis or sarcoidosis, milk alkali syndrome, basically somebody who's eating too many antacids, hyperthyroidism, adrenal insufficiency, immobilization, Paget's disease, acromegaly, and familial hypocalciuric hypercalcemia. So all of these other things are much less common causes of hypercalcemia, but still ones that you might need to be aware of. So usually once the calcium level rises above 12 milligrams per deciliter, that's when your patients start to show symptoms. So polyuria, kidney stones, they might have anorexia, vomiting, constipation. They might get pancreatitis from it, weakness, fatigue, confusion, stupor, coma. And then if it's sort of long-standing and the hyperparathyroidism is going on, they might have fractures, and that actually might be how they present to you. I always learned in medical school, hypercalcemia was the bones, moans, and psychic groans. So the idea that they can have bone issues like fractures, they can moan because they have abdominal pain or because they're confused, and then psychic groans because, again, they get that stuporous state. So how do you evaluate these patients? So again, looking at a corrected calcium or ionized calcium to ensure that you're getting a true calcium reading. You want to do what's called an intact PTH. If you suspect malignancy, you might need to do the PTH-RP or the PTH-related peptide. Check vitamin D levels, both a 25-hydroxy and a 1,25-dihydroxy. Check the phosphorus, look at a urinary calcium, and look at that EKG. Again, hypercalcemia can cause a shortened QT and even lead to things like AV blocks, so you want to be mindful of that. Hypercalcemia is usually a pretty urgent one to take care of. These people usually, once they get that high level, they really need aggressive treatment. And the number one thing you do is you give them a ton of fluids. You give them as much IV fluid as they can tolerate, trying to get that urine output about 100 to 150 milliliters per hour. You can give loop diuretics such as Lasix that will decrease the resorption of calcium in the loop of Henle. They have IV bisphosphonates such as pamidronate. You can give a dose of 60 milligrams IV over the first 2 to 4 hours. You can go as high as 90 milligrams. There's an intranasal there's an intramuscular or a subcutaneous injection of calcitonin that you can use 4 to 8 international units per kilogram. If they have etiologies from malignancy or granulomatous disease like sarcoid, you can use steroids like prednisone, and in severe cases, dialysis. Hypocalcemia on the other spectrum acutely can be seen in just anybody who's critically ill. Sepsis, burns, renal failure. Patients who get lots of blood products that are citrated can actually develop hypocalcemia. Certain medications can lead to it, like protamine, heparin, and glucagon. Pancreatitis can actually cause a consumption of calcium and lead to hypocalcemia. And then other states that cause hyperphosphatemia, such as tumor lysis, renal failure, and rhabdo, can then consume calcium levels as well. More chronically, hypoparathyroidism, hypomagnesemia, renal failure, and vitamin D deficiency are the areas that you see hypocalcemia. And at least here in the United States, we see a ton of this with renal disease and vitamin D deficiency. You can look at hypocalcemia from the standpoint of what the PTH level is doing. So if they have no PTH, they have hypoparathyroidism from either a hereditary or an acquired cause, or they have a hypomagnesemic state. If the PTH is there, it's high, it's just not, it's being overwhelmed. That can be from a very high hyperphosphatemic state, or they could have osteitis fibrosa after parathyroidectomy. On the other hand, if they have PTH and it's just not working, that could be because the kidneys aren't working well, they're in renal failure. They don't have active vitamin D, so either their diet's bad or they don't get out in the sun. They could be on certain medications like convulsants that actually inhibit that vitamin D activity. They can have ineffective vitamin D, meaning they just can't absorb it well, or they can have pseudo-hypoparathyroidism. The symptoms of hypocalcemia, paresthesias is really the most common thing that people will complain of. They'll complain of tingling in their hands and feet. They may have it around their mouth, perioral. There's a couple sort of classic signs, Trousseau's sign. So that's where you, carpopedal spasm. So you inflate a blood pressure cuff and you get this very characteristic contraction at the metacarpal and extension at the interphalangeal joints in the hands. Schwastek's sign, where you tap on the facial nerve and you get like a spasm of the face muscles. They can have laryngospasm, seizures, dysfunction of the myocardium, QT prolongation, and even sudden death. So generally, you're going to pick up the the calcium issue before they get to that point. But again, these would be the things you'd look for from a symptom standpoint. So how do you evaluate them? Usually you double check it, measure it again, check their albumin, see whether it needs corrected for the albumin level, check their PTH, their phosphorus, their creatinine, the 25-hydroxyvitamin D, and then the 24-hour urine calcium really gets to that one very small subset of patients that have the familial hypocalciuric hypercalcemia. So that's what the 24-hour urine calcium is going to get. How do you treat these patients? IV calcium gluconate. Typically, you can put 90 milligrams in a 50 ml bag of D5 or normal saline and infuse it over a 5-minute period. And then you can give them a longer infusion of 90 milligrams over a 24-hour period. And if they have any magnesium levels that are low, you make sure you replete that as well. More chronically, so these are your renal patients, your vitamin D deficient patients, generally calcium carbonate or calcium citrate, 1,000 to 3,000 milligrams daily. Vitamin D at a 1,000 to 4,000 international units per day level. If they have renal failure and they have a low PTH level, they oftentimes will need a calcitriol formulation instead. If their phosphate is high, make sure you're giving them phosphate binders for that. And then in severe cases where the PTH is just not working, there is a recombinant PTH that you can use. All right, last section is phosphorus. Again, similar to calcium, it's mainly found in the bone and intracellular spaces. You need it for metabolic pathways. Think ATP, adenosine triphosphate, cellular repair, and enzyme activity. So symptoms of hypophosphatemia. So if the phosphate's a little bit low, less than 2.7, usually not a problem. Moderate, if they're down below 2, they might feel weak. If it's below 1, that's when it's really life-threatening. So this is where they have like those alterations in mental status, seizures, respiratory failure, etc. Why does it happen? So really sort of broad strokes similar to the others. Shifts from intra to extracellular, decreased intake, and increased excretion. So thinking about things like refeeding syndromes in the ICU or insulin usage, that sometimes will cause hypophosphatemia. Meds that bind phosphate in the gut, so antacids and calcium binders, those will do it. And then diarrhea or wasting in the kidneys. How do you treat it? We use sodium phosphate or potassium phosphate, PO, if it's mild. You can use IV sodium phosphate if it's more severe. And you can infuse this basically in 500 mLs of saline over 6 hours, where a 1 millimole dose of phosphate gives you 31 milligrams of phosphorus, and you just base it on their weight. You usually have to give 24 to 36 hours of repletion to really get their level back to normal. But once they hit about a 1.5, you can usually put them back on oral therapy. Occasionally, you can use some calcitriol to help with the intestinal absorption of phosphate because it comes along with the calcium. Hyperphosphatemia, very briefly, because you don't see this a lot, it's a level greater than 4.5. It's usually only because the kidneys aren't working or because they're having a release from cells, so tumor lysis, rhabdomyolysis, etc. The one intake thing to keep in mind, usually it's not a dietary intake unless they have kidney disease. Sometimes it's that they're using phosphate-containing enemas. So remember, that is, Fleet's phosphosodium enemas. They're very effective, but it's a big phosphate load, so you can see a transient hyperphosphatemia in those patients. There's really no symptoms to hyperphosphatemia because the body typically fixes itself in about 12 to 24 hours. On the other hand, the hyperphosphatemia can then lead to problems with the calcium levels and the magnesium levels, especially in your kidney patients who have a reduced GFR. So those are the patients that need those calcium binders, might need dialysis. But usually the symptoms of hyperphosphatemia are due to the calcium being low, not the phosphate itself. All right, so that concludes sort of our discussion about the sort of big 5 electrolytes. In summary, always, just like with everything, take a good history, do a good exam, try to figure out why the problem happened. We can do lots of things, just knee-jerk, fix the problem, fix the lab result, but really the problem is figuring out why did it happen in the first place. There are some charts and some formulas that you just need to keep handy for your reference, such as that hyponatremia chart, because it is a little bit involved. You want to make sure you identify symptoms that go with the different electrolyte disorders, and then know sort of your local formulations that are available to use for repletion, both in an oral form as well as an IV. If you want to look up some of my references, I used a couple different editions of Harrison's Principles of Internal Medicine. There's a book called The Washington Manual of Medical Therapeutics that gave me some good sort of quick and dirty how to approach some of the electrolytes, and then the mix app for some of those charts I showed you. So thank you so much, and if you guys have any questions, I'll take those.